Hello everybody. Today's topic is acute heart failure. So acute decompensated heart failure presenting with the cardiogenic shock occurs in approximately 2% of hospitalization but requires immediate recognition in the critical care. The hemodynamic classification of acute decompensated heart failure by congestion, that is wet or dry, and cardiac output, that is warm or cold, is important distinction, with warm and wet profile characterizing more than 80% of patients admitted with the acute decompensated heart failure. Approximately 20% of all acute decompensated heart failure patients have de novo heart failure and require evaluation to ascertain the etiology of new onset heart failure. Patients with the worsening of chronic heart failure require investigation into possible precipitant and therapies to address these precipitants. Acute decompensated heart failure hospitalization are divided almost equally between the patient with heart failure with reduced ejection fraction and patient with heart failure with preserved ejection fraction. With the use of therapies targeting cardiovascular hemodynamics largely differing between these two groups. Lastly, the assessment of comorbidities, organ dysfunction, and lab abnormalities are pivotal for risk prognosis, prognostication, and therapeutic management. So regarding this is the algorithm describing the initial approach for the heart failure patient. So initial approach for the acute decompensated heart failure, we need to assess whether the patient is in cardiogenic shock or not. If the patient is in cardiogenic shock, initiate appropriate pharmacological measures and mechanical circulatory support. Then we need to assess whether the patient is in respiratory failure or not. If the patient is in respiratory failure, then provide the adequate respiratory support in the form of NIV and mechanical ventilation as soon as possible and as appropriate. If the patient is not in cardiogenic shock and the patient is not in respiratory failure, then assess the hemodynamic status of the patient and according to the hemodynamic status, divide the patient into four groups, that is warm, dry, warm, wet, cold, dry, and the cold, wet. Then select according to that, select the diuretic and appropriate vasoactive therapies. Then, if there is a new onset of heart failure, then evaluate the heart failure, then try to find out the etiology of the heart failure. If it is not new onset, then assess for the ventricular systolic function and classify it as heart failure with reduced ejection fraction or heart failure with preserved ejection fraction. If it is a heart failure with reduced ejection fraction, then optimize the goal-directed medical therapy. If it is heart failure with preserved ejection fraction, then consider spironolactone and sacubitril valsartan. Treat the exacerbating comorbid conditions, then identify the precipitant factors and the risk assessment, and then select the therapies. So this is so so the bottom line is cardiogenic shock, respiratory failure should be immediately evaluated and treated. Patient should be then classified by hemodynamic quadrant, that is new onset versus decompensated chronic heart failure, left ventricular ejection fraction, precipitant of the acute decompensated heart failure, and prognostic variables. So this acute decompensated heart failure patient is divided into heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. If the ejection fraction is less than 40%, then it is a heart failure with reduced ejection fraction. If it is the ejection fraction is more than 50%, then it is a heart failure with preserved ejection fraction. So according to the hemodynamics, the patient need to be classified into the four categories. So we need to see if the signs of congestion are there or not, and if the signs of low hypoperfusion are there or not. Signs of congestion at rest includes elevation, orthopnea, high JVP, increased S3, loud P2, edema, ascites, rails, abdominal jugular reflex, and Valsalva square test. And the signs of low perfusion includes narrow pulse pressure, pulsus alterans, cool extremities. Then patient may be sleepy and often dead. AC inhibitor related, symptomatic hypotension, then declining serum sodium level and worsening renal function. And then according to that, the patient need to be classified into four categories. If there are no signs of congestion and if there are no signs of low perfusion, then the patient is warm and dry. If the congestion is present but there are no signs of hypoperfusion, then the patient is warm and weight. If there are the signs of low perfusion, but there are not signs of congestion, then the patient is cold but dry. And if signs of congestion is present along with the low perfusion, then the patient is cold and wet. So regarding pathophysiological consideration, a variety of pathophysiological mechanism may be responsible for heart failure, acute decompensated heart failure episodes, comorbidities, particularly poorly controlled hypertension, new onset atrial fibrillation, worsening valvular dysfunction, active myocardial ischemia may contribute to acute decompensation. For most mechanisms leading to acute decompensated heart failure, volume overload with pulmonary and venous congestion is predominant result, leading to hospitalization with hemodynamic measurements typically finding increased right and the left-sided ventricular filling pressures. Traditionally, congestion was assumed to develop gradually with increased sodium and water intake or renal reabsorption, causing incremental increase in total body volume and corresponding intracardiac pressure until symptom severity warrants urgent care. However, elevation of cardiac pressure may precede or occur independently of total body volume increases in the patient with acute decompensated heart failure. Sympathetic activation alter the venous capacitance, shifting the volume from venous reservoir, such as flanking circulation, towards the heart, increasing filling pressure without a change in the total body volume. While the weight gain is the simple surrogate of worsening heart failure, easily performed by patient, it will not be sensitive warning for some patients. Predictors of the prognosis, admission, vital sign, low blood pressure, tachycardia. Then, according to the lab value, increased serum creatinine, increased blood urea nitrogen, hyponatremia, hypochloremia, increased cardiac troponin, then the elevation of the natriuretic peptide. Then, according to the treatment response, inability to achieve decongestion and decrease uh, natriuretic peptide, then diuretic resistance, inability to tolerate guideline mediated therapies. The admission vital sign and the basic metabolic panel predict in hospital outcome with hypotension and renal dysfunction signify the greatest risk. The relationship between kidney function and the heart failure outcome is complex. Low glomerular filtration rate and the elevated blood urea nitrogen are powerful indicators of adverse outcome in acute decompensated heart failure, yet mild to moderate increase in the serum creatinine from the renal angiotensin aldosterone system inhibitors or decongestion are associated with neutral to better prognosis. Therefore, careful attention to the clinical context when interpreting the prognostic information from kidney function is warranted. The utility of the biomarkers, particularly BNP and pro-BNP, are useful for identifying patients at increased risk of readmission or death. However, it should be recognized that a variety of etiologies, including pulmonary embolism, acute coronary syndrome, sepsis, may also lead to the markedly elevated BNP, while obesity decreases the natriuretic peptide. Troponin release occurs in 30% to 70% of acute decompensated heart failure patients, and its elevation is associated with twofold increase in the post-discharge mortality and threefold increase in the rehospitalization rate. Early identification of the high-risk patient may ultimately lead to better strategies designed to improve their in-hospital outcomes. In addition to admission parameters, treating response can further define risk prognostication. Inability to tolerate guideline-directed medical therapies should signal clinician to consider evaluation for advanced therapeutic options such as heart transplantation. Diuretic resistance, quantitatively defined as poor diuretic response despite adequate diuretic regimen, is independently associated with worse prognosis. In the same vein, failure to achieve decongestion prior to hospital discharge increase the risk of rehospitalization and mortality, emphasizing the importance of ensuring the patient is euvolemic prior to discharge. Assessment of the congestion in acute decompensated heart failure. Dyspnea is the most common symptom of hypervolemic acute decompensated heart failure, presenting with exertion at rest and position. Additional symptoms indicating congestion include peripheral edema, abdominal swelling, and early satiety. So, as no one sign has adequate sensitivity and specificity to diagnose congestion, the clinician's assessment involve evaluation of multiple signs and clinical judgment of overall volume status. Elevated jugular venous pressure, hepatojugular reflux, orthopnea, bendopnea, S3 heart sound, presence of peripheral edema should be evaluated. Rales and pulmonary edema on chest radiography can be absent despite the presence of acute decompensated heart failure, secondary to increased lymphatic drainage with chronic heart failure. Congestion assessment can be supplemented with non-invasive imaging, such as presence of B lines on lung ultrasonography and inferior vena cava size on echocardiography, and bioimpedance measurement of cardiac pacemaker and defibrillator. Lastly, query of implanted wireless pulmonary artery pressure monitoring devices is also possible to substantiate the assessment above. Then pharmacological management of acute decompensated heart failure. Congestion is the most common cause for the admission for acute decompensated heart failure and should be aggressively treated with intravenous loop diuretic when present. By and large, the diuretic therapy for volume overload should not differ by ejection fraction, etiology, and precipitation. In an attempt to achieve net negative sodium and fluid balance, sodium should be less than 2 to 3 grams and the fluid restriction should be less than 2 liters per day is commonly recommended. However, the optimal sodium intake in heart failure is unknown and the patients with resistance to decongestive therapy may counterintuitively benefit from increased sodium intake if combined with diuretic. Furthermore, a trial of intensive sodium that is less than 800 mg per day and the fluid restriction that is less than 800 ml per day found no benefit across the several decongestive methods. Sodium and the fluid restriction should be individualized according to lab values and treatment response. Diuretics are the cornerstone for relieving congestive symptoms. IV loop diuretics are the first line diuretic therapy. The decision between IV loop diuretic is arbitrary in most patients as both are efficacious when prescribed as equipotent dose, and bumetanide superior bioavailability is irrelevant with IV administration. That is 1 mg of bumetanide is approximately equal to the 40 mg of the furosemide. At higher doses and with the renal dysfunction, there are theoretical advantages to furosemide with respect to efficacy. However, bumetanide appears to be substantially less ototoxic at higher doses, offering an advantage to the use of bumetanide. Bumetanide can cause severe diffuse myalgias, particularly at higher continuous infusion rates. Myalgias do occur but appear less frequent with bolus dosing of IV bumetanide. Selection of IV diuretic dose is critical because of sigmoidal dose response relationship. The diuretic dose must produce diuretic concentration that exceeds the threshold to elicit natriuresis. For loop diuretic new patient, this is often 40 to 80 mg of IV furosemide. In patient with the chronic heart failure, the dose response curve is shifted to the right, requiring increased dose to achieve natriuresis. The dose heart failure trial demonstrated that multiplying the oral diuretic dose by approximately 2.5 improves the fluid and the weight loss. The dose heart failure trial failed to demonstrate significant difference in patients' global assessment of symptom, metric of diuretic response, or kidney function when loop diuretic were administered to the same total daily dose by intermittent bolus compared with the continuous infusion. So either dosing strategy is accepted. So this is the figure showing the loop diuretic dose response curve. So loop diuretic dose response, the minimal diuretic effect is seen until the threshold is reached, beyond which ceiling effect is reached. Note that the x-axis for the diuretic dose is on the log scale, meaning substantial diuretic dose increase are required to achieve increase in diuretic effect. In patients with acute decompensated heart failure, the dose response curve shifted downward and to the right. Subsequent diuretic dosing should be guided by the response to previous dose to achieve the goal rate of the dialysis. Historically, the diuretic response is measured as urine output and the weight loss 12 to 24 hours later with goal urine output of 3 to 5 liters daily. Yet this standard approach has several limitations. First, significant time is wasted during diuretic titration, and diuretic duration action rarely exceeds 6 hours following IV use. Second, measures of weight and the net fluid balance are inaccurate in hospital. Finally, the weight and the fluid loss assumes the rate of sodium excretion is equal for all patients. Urinary sodium excretion to loop diuretic therapy is highly variable, with poor natriuresis associated with worse outcome, even for patients reported to achieve net negative fluid status. As a result, the evidence is accumulating for urine sodium based diuretic evaluation and titration strategy, and this approach is increasingly recommended. So urine sodium concentration less than 50 to 70 in urine sample collected 1 to 2 hours after diuretic indicate poor response. And if urine sodium concentration is more than 100 nmol per liter indicate good response. So the natriuretic response prediction equation has improved upon the urine sodium alone to predict the diuretic response from spot urine sample. So diuretic response should be assessed as urine volume within the 6 hours of either urine sodium or a natriuretic prediction equation within 2 hours. The diuretic dose can be titrated immediately to quickly achieve the goal diuretic response. So the diuretic titration should initially focus on identifying dose required to produce adequate diuretic response. The dose should then be repeated as necessary to achieve the goal decongestive rate expressed as either net fluid loss or more ideally net sodium loss. While these goals should be individualized to each patient, common goal include fluid loss of 3 to 5 liter per day and urine sodium excretion of 230 to 500 ml per day. So this is the schematic representation of titrating diuretic therapy. So first, empirical IV diuretic dose administered as 2.5 times the home dose in divided dose or furosemide 80 mg if the patient is not on any loop diuretic. Then we need to assess the urine analysis strategy and urine outflow strategy. In urine analysis, we need to measure the spot urinary sodium. If spot urinary sodium is and this NRP, or if natriuretic peptide response, we need to assess for 1 to 2 hours. If this spot urinary sodium is more than 100, then it is a and if simultaneously we also need to look for the urine output. So if this spot sodium, if this spot urinary sodium is more than 100, and if the urinary output in the 2 to 6 hours is more than 150, then it is an adequate response. Then we need to repeat the current dose and we need to repeat the urinary sodium and assess for the urine output. But if the urinary sodium is less than 100 and if the urinary output is less than 150, then administer the loop diuretic at double the previous dose and repeat up to IV loop diuretic dose of 500 mg of furosemide equivalent. If it is a failure to meet, despite increasing dose, if failure to meet the target level of the urinary sodium and urine output, then the combination of the diuretic blockage with the loop diuretic is needed. So first add thiazide and the second line diuretic for additional decongestive agent include acetazolamide, amiloride, tolvaptan, 3% NaCl, and SGLT2 inhibitor. The diuretic resistance is subjectively defined as inadequate rate of diuresis and natriuresis despite adequate diuretic dose. While no quantitative diuretic resistance definition with universally utility exists, the diuretic efficiency has demonstrated the prognostic value in multiple acute decompensated heart failure patients. Diuretic efficiency expressed as urine sodium excretion or weight changes relative to diuretic dose administered, with patient exhibiting low diuretic efficiency and high dose diuretics having worse outcome. Once identified, the mechanism of diuretic resistance should be considered to guide therapeutic intervention. Although diverse mechanisms of diuretic resistance in acute decompensated heart failure are overwhelmingly intrarenal rather than the peripheral. Therefore, outside of setting of cardiogenic shock, inotropic and vasodilator therapies have limited impact on diuretic response on population level. Among intrarenal mechanisms, diminished loop diuretic response at loop of Henle and distal tubular sodium absorption have the greatest influence over diuretic response in acute decompensated heart failure. So most experts recommended the prioritizing loop diuretic dose escalation first, as combination diuretic therapy with thiazide are associated with the more electrolyte abnormalities and worse outcomes. Although no consequence exists as to loop diuretic dose at which thiazide should be added, experience suggests the loop diuretic doses can safely exceed the commonly reported maximum dose. So bolus dose of IV bumetanide up to 12.5 mg and IV furosemide of 500 mg have precedence and may be required in resistant cases. Any thiazide can be utilized to oral metalazone and IV chlorothiazide are most commonly utilized medication for diuretic combination therapy. Contrary to the classic teaching, there is a no classical rationale in dosing thiazide 30 minutes prior to the loop diuretic. IV chlorothiazide should be given concurrently with the IV loop diuretic, with oral thiazide delayed absorption and longer half-life render synchronized administration irrelevant. Several other decongestive therapies have theoretical utility for diuretic resistance, generally in addition to combination diuretic therapy for individual patients. However, the evidence to support any of the following therapy is limited and is often cut. Acetazolamide and SGLT2 inhibitor have demonstrated combination diuretic benefit with loop diuretic and are currently being studied for acute decompensated heart failure. Tolvaptan is the vasopressin 2 receptor antagonist, can augment the loop diuretic response but causes less natriuresis than the combination with the thiazide. If used to augment the diuretic response, mineralocorticoid antagonist should be dosed more than 100 mg per day. Hypertonic saline bolus combined with the diuretic therapy may increase diuretic response but require appropriate. Ultrafiltration using veno-venous access approach is an alternative approach to volume removal in acute decompensated heart failure. Several studies have compared the diuretic therapies to ultrafiltration, although issues of early termination or design have limited definitive conclusion. KRS heart failure compared ultrafiltration to the state care diuretic algorithm for patients with acute decompensated heart failure with worsening kidney function. Weight loss at 96 hours was similar, but ultrafiltration was associated with greater rise in serum creatinine and moderate adverse event. Importantly, hemodynamic instability have been the exclusion criteria for all published studies. Then, despite early hopes, the ultrafiltration is not routinely used due to cost and need for systemic anticoagulation and increased adverse events. Then next is acute vasodilator therapy. Unlike diuretic therapy, the use of acute vasodilator therapies differ between the acute heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. In the acute treatment of heart failure with reduced ejection fraction, acute vasodilator therapies targeted at reducing elevated preload and afterload can increase cardiac output significantly and theoretically provide rapid reduction in acute decompensated heart failure symptoms. However, in acute heart failure with preserved ejection fraction, systolic function is preserved and the reductions in afterload lead to marginal increase in cardiac output. IV vasodilator for heart failure with preserved ejection fraction are much more likely to reduce stroke volume and cause hypotension than heart failure with reduced ejection fraction. So unless treating and hypertensive and emergency, acute arterial vasodilator therapies are primarily beneficial in patients with heart failure with reduced ejection fraction. Vasodilators can benefit selected heart failure with preserved ejection fraction and heart failure with reduced ejection fraction patients by lowering filling pressure and improving symptoms. For heart failure with reduced ejection fraction, appropriate patient selection and clear understanding of acute vasodilator therapy goal are important. The continuation of chronic and the oral vasodilator medications prescribed to reduce morbidity and mortality is different than initiation and rapid titration of the vasodilators, that is nitroglycerin and sodium nitroprusside, to acutely improve hemodynamics and a discussed setting. In undifferentiated population presenting with acute decompensated heart failure from heart failure with reduced ejection fraction, randomized trial of routine use of oral and IV vasodilator have not improved in hospital and post-discharge outcome. Additionally, vasodilator therapy have not improved diuretic response. IV vasodilator therapies can be added to diuretic therapy for acute dyspnea relief for patients with adequate blood pressure. Acute decompensated heart failure population that may benefit include hypertensive urgency, emergency, dyspnea with impending respiratory failure, elevated systemic vascular resistance on invasive hemodynamic monitoring. Oral and IV vasodilator with evidences for use are listed. Generally, these medications are characterized by rapid onset of action and short half-life to facilitate rapid titration. Organic nitrates are predominantly venodilator at low doses, causing rapid reduction in ventricular filling pressure and dyspnea symptoms. Arterial vasodilator occurs at high doses. Tolerance develops within hours without nitrate-free interval of 8 to 12 hours per day. Although combined use with the hydralazine and the other antioxidant may prevent the tolerance. The combination of hydralazine in oral nitrate provide the joint preload and afterload reduction. The combination can be used when angiotensin converting enzyme inhibitor and angiotensin receptor blocker are not feasible in conditions such as severe kidney dysfunction, hyperkalemia, or pregnancy. Sodium nitroprusside is the potent balance arterial and the venodilator and utility in the acute decompensated heart failure complicated by hypertensive crisis or severe mitral regurgitation causing respiratory distress. Cyanide is the product of nitroprusside metabolism. High infusion rate, that is more than 4 to 5 microgram per kg per minute for more than 48 hours, and severe kidney and hepatic dysfunction increase the risk of cyanide toxicity. Nitroprusside is best utilized as short-term therapy until more definitive therapies can be initiated. Then this is the list of the IV and the oral vasodilator. IV vasodilators are enalaprilate, which can be used in the dose of 1.5 mg every 6 to 8 hours. The effects are both venous and arterial dilator. Nitroprusside can be used in the dose of 0.2 microgram per kg per hour. It is a balanced venous and the arterial dilator. Then, but the continuous arterial pressure monitoring is required. Cyanide toxicity with IV and the oral dose with prolonged use is possible. Then the nitroglyceride is used in the dose of 10 microgram per minute. It is the predominantly venous dilation and the arterial dilation occurs at higher doses. So headache is common side effect. Tolerance begins within the hours and requires dose escalation for constant effect. Then for oral vasodilators, there are three drugs like hydralazine, isosorbate dinitrate, and captopril. Hydralazine can be used in the dose of 25 mg every 6 to 8 hours. Then it is a predominantly arterial dilator, commonly combined together with the venous and arterial dilation. Then isosorbate nitrate is used in the dose of 10 mg every 6 to 8 hours. Then it has predominantly venous dilation effect. Captopril is used in the dose of 6.25 mg every 8 hours. It has a both venous and the arterial dilation. Initiation and the continuation of the guideline-directed medical therapy. Unless clinical circumstances necessitate the temporary cessation, most outpatient goal-directed medical therapy should be continued during acute decompensated heart failure. After triage of acute decompensated heart failure and determination of the adequate diuretic regimen, attention should be directed towards optimization of the chronic goal-directed medical therapy. This goal-directed medical therapy is referred substantially for heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. Heart failure with reduced ejection fraction. Evidence support in hospital initiation of AC inhibitor, ARB, sacubitril, valsartan, beta blocker, mineralocorticoid antagonist, so SGLT2 inhibitor for hemodynamically stable patients who are appropriate candidates. For heart failure with preserved ejection fraction, continuation of mineralocorticoid antagonist is reasonable for hemodynamically stable patients who are appropriate candidates. In heart failure with preserved ejection fraction, antihypertensive therapies can be continued for blood pressure control but should be discontinued when hypotension occurs. Regarding AC inhibitors, ARB and ARNI, in hospital initiation and titration of AC, ARB and ARNI for heart failure with reduced ejection fraction is nearly identical to outpatient setting, including serum creatinine, serum potassium, and blood pressure monitoring. Mild increase in serum creatinine, generally up to three times increases from the baseline, is associated with initiation or titration of these therapies and are associated with improved prognosis and should not form the therapy discontinuation. AC and ARBs often improve the natriuresis during loop diuretic therapy. RNA is preferred over AC or ARB in patients that can tolerate the blood pressure reduction and do not have contraindications such as history of angioedema. Beta adrenergic blocker have been shown to lower all-cause mortality and decrease heart failure hospitalization in variety of randomized controlled trial in patients with the heart failure with reduced ejection fraction and NYHA class 2 to 4 symptoms. The mortality benefit of beta blocker therapy for patients with advanced heart failure symptoms are clearly established. The carvedilol prospective randomized cumulative survival trial, that is Copernicus trial, evaluated patients with severe symptoms and the left ventricular ejection fraction less than 25%. So carvedilol reduces the all-cause mortality and hospital days for acute heart failure decompensation. Beta blocker can be safely continued at same outpatient dose unless hypotension, bradycardia, cardiogenic shock is suspected. Despite the long-term mortality advantages, beta blocker are negative inotropes and will worsen the cardiac hemodynamic acutely. So hemodynamic stability is important prior to initiation. For initiation, low doses of either bisoprolol, carvedilol, metoprolol should be initiated once the patient is hemodynamically stable and either euvolemic and rapidly decongesting with diuretic therapy. Shorter acting metoprolol titrate can be used to ensure the patient tolerate beta blocker initiation, but metoprolol should be transitioned to extended release formulation like metoprolol succinate and another evidence-based beta blocker prior to discharge. Generally, beta blocker doses are not increased rapidly out of concern of precipitating acute decompensated heart failure from negative inotropic effects. Then the next is mineralocorticoid antagonist. Spironolactone has beneficial effect for both, that is heart failure with reduced ejection fraction and heart failure with preserved ejection fraction, and doses between 12.5 to 50 mg. Importantly, the reduction in mortality in heart failure with reduced ejection fraction and reduction in hospitalization in heart failure with preserved ejection fraction are largely independent of diuretic action. Spironolactone does not acutely or significantly lower the blood pressure of normotensive patient and can raise serum potassium. It is an attractive medication to continue or initiate during acute decompensated heart failure hospitalization. Higher doses, that is 100 mg daily, were not shown to be more beneficial for patients hospitalized with acute decompensated heart failure. Higher doses have theoretical benefit as diuretic adjuvant although evidence is inconclusive and limited. High doses can be used for potassium sparing effect for patients with potassium wasting. Eplerenone is an equally efficacious mineralocorticoid antagonist, unlike spironolactone, and it does not cause gynecomastia. SGLT2 inhibitors are an emerging therapy for heart failure with reduced ejection fraction, providing reduction in mortality and morbidity chronically for patients with and without type 2 diabetes mellitus. SGLT2 inhibitor, which cause both glycosuria and uh, synergistic natriuresis with loop diuretic, have potential benefit in acute decompensated heart failure as well. Presently, SGLT2 inhibitors are considered safe to start prior to hospital discharge, and early initiation for treatment of acute decompensated heart failure is being investigated. Then digitalis. Digoxin continue to have role for the management of patient with advanced acute heart failure with reduced ejection fraction. Digoxin has positive inotropic effect in cardiac muscle, reduces activation of sympathetic and renin angiotensin system, and partially restores the favorable inhibitory effect of cardiac vasoreceptor function. Although digoxin does not reduce the mortality, chronic digoxin administration increases the left ventricular ejection fraction, improves exercise capacity, decreases the advanced heart failure symptom, and reduces the heart failure associated hospitalization. As a caveat, this evidence was generated prior to contemporary goal directed medical therapy. It is unknown if these results are reproducible on contemporary goal directed medical therapy. While identification of ideal patient for digoxin is complex, patients during heart failure, acute decompensated heart failure can be candidate for digoxin if they are intolerant to or persistently symptomatic with limited doses of goal-directed medical therapy due to hypotension or symptomatic from atrial fibrillation with rapid ventricular rate and intolerant of beta blocker. Discontinuation of digoxin is associated with increased risk of hospitalization for acute decompensated heart failure. Thus, digoxin should be permanently discontinued if benefit outweighs this risk. However, digoxin is primarily renally eliminated and has small therapeutic serum range. That is a symptom of toxicity about 2 mg per ml. Measurement of serum digoxin level and dose adjustment may be necessary if renal function deteriorates during acute decompensated heart failure. Regarding intravenous therapy, the current heart failure guideline recommended screening for iron deficiency and treating iron deficiency with IV iron. Iron deficiency occurs in approximately 50% to 80% of patients hospitalized with acute decompensated heart failure and remain equally prevalent in patients without it. So in patient with heart failure with reduced ejection fraction and iron deficiency, defined as serum ferritin less than 100 and serum ferritin of 100 to 300 mg per dl, with transparent saturation less than 20%, iron repletion with the iron reduces acute decompensated heart failure hospitalization risk and improves both exercise capacity and quality of life. Importantly, this benefit is similar for patients with or without concomitant anemia and has not been replicated in rigorous studies of oral iron therapy. Recently, the AFFIRM heart failure trial establishes the safety and efficacy of IV iron repletion during acute decompensated heart failure hospitalization. Once iron deficiency is diagnosed, the magnitude of iron deficiency can be calculated using Ganzoni equation. A total repletion dose of 1000 to 1500 mg divided dose depending on IV iron formulation is commonly required. Then regarding intensive care management of advanced acute decompensated heart failure, intravenous positive inotrope. IV positive inotropes and inodilator medication increases the cardiac output primarily through intracellular calcium mediated inotropy of cardiac myocyte. Dobutamine and dopamine increases inotropy via beta receptor agonism, while milrinone inhibits the phosphodiesterase 3 from metabolizing cyclic CM. Despite the theoretical attractiveness of positive inotropy in heart failure with reduced ejection fraction, improvement in the hemodynamics, multiple clinical trials have demonstrated the increased adverse event, including increased mortality with positive inotropic medications. The adverse event of positive inotropy from increased intracellular calcium are inextricably linked to the mechanism of action, which increases the myocardial oxygen demand and increases arrhythmia risk. Even 48 hours of migrenon increases the arrhythmia and hypotensive episode related to placebo in randomized trial of acute decompensated heart failure patients. Currently, IV inotrope are only recommended for patients with advanced heart failure with reduced ejection fraction, complicated by cardiogenic shock as a short-term therapy to maintain systemic perfusion and end-organ function. Long-term therapy should be reserved for inotrope-dependent patients as a bridge to either heart transplantation, mechanical cardiac support, and palliative care. Despite this guideline, the considerable heterogeneity continues to exist regarding the usage of heavy positive inotropic agents. Then IV inotropes are used in approximately 6% of acute decompensated heart failure hospitalization, despite the wide institutional variation that is not explained by the illness severity. Selection of the specific inotropic medication is dependent on several clinical considerations, and in practice, the difference between agents are likely of more theoretical than practical importance. Milrinone has longer half-life, increasing time to steady state with initiation. A loading dose of IV bolus can be used to increase time to initial effect. However, this is associated with substantially more hypotension and is generally omitted in the clinical practice. For patients with low blood pressure, dopamine has least reduction of blood pressure, followed by dobutamine and milrinone, causing greatest decrease in the blood pressure. To the contrary, for patients with elevated systemic vascular resistance, milrinone can be particularly useful due to this vasodilatory effect. Milrinone is also renally eliminated, necessitating dose adjustment, unlike other inotropes. By and large, the beta blocker should be discontinued if low cardiac output necessitates inotropic therapy. Recent beta blocker administration will directly antagonize the beta-mediated effect of dopamine, and attenuate the response. Milrinone may be preferentially chosen, and high dopamine infusion rate may be temporarily required. Now, the trajectory of the acute decompensated heart failure hospital course. Uh, First one is worsening kidney function. Worsening kidney function during decongestion is common, occurring in up to one half of the acute decompensated heart failure patient, although deterioration are typically mild and transient. Similarly to the assessment of baseline kidney function, clinical context is vital to interpreting changes of GFR, glomerular filtration during decongestion. Mild to moderate increase of serum creatinine during IV diuresis are not associated with worsening marker of tubular injury and are therefore distinct from traditional cause of acute kidney injury resulting in the acute tubular necrosis. Worsening renal function should not automatically stop the diuretic therapy and be interpreted as achievement of euvolemia. Worsening kidney function with residual congestion is associated with worse prognosis compared to decongestion accompanied by the worsening kidney failure. Thus, IV diuretic therapy should be continued for patients with persistent hypervolemia and mild to moderate increase of serum creatinine. Unfortunately, lab markers of renal tubular injury are not helpful for guiding therapy decision. Then BNP guided therapy. Failure to decrease BNP or NT-proBNP of more than equal to 30% from admission value have been associated with elevated risk of readmission in observational study promoting investigation into BNP guided therapies. Randomized trial of NT-proBNP guided therapy was compared to conventional treatment with goal of achieving more than 30% reduction from admission. Despite greater NT-proBNP reduction of at least 30% in treatment arm, natriuretic peptide-guided therapy did not improve 180-day all-cause mortality, heart failure hospitalization, days alive out of the hospital, and secondary endpoint. Presently, no individual lab value aids in the treatment of worsening heart failure. Then hemodynamic guided therapy. Invasive hemodynamic monitoring using indwelling pulmonary artery catheter is not recommended for routine use as it fails to improve outcome over clinical assessment alone for patients without clear indication of for invasive hemodynamic monitoring. However, invasive hemodynamic monitoring is recommended in several clinical scenarios, such as worsening heart failure and unclear hemodynamic profile. Risk of pulmonary artery catheter include infection, bleeding, arrhythmias. Invasive hemodynamic monitoring is not therapy itself, but rather provides measure of feeling pressure, cardiac output, vascular resistance to clarify patient's hemodynamic status and guide therapeutic decision. Following initial assessment of baseline hemodynamic, IV diuretics, vasodilator, positive inotropes are administered to achieve desired hemodynamic. Goal filling pressures are commonly right atrial pressure less than 8 mmHg, pulmonary capillary wedge pressure below 15 mmHg, which can be achieved with diuresis and vasodilator. Using arterial vasodilator, the goal of systemic vascular resistance is between 1000 to 1200 dyne second per centimeter. If cardiac index is below 2.2, after optimizing hemodynamic variable and is very low at baseline, positive inotropic agent can be considered. Following hemodynamic optimization, oral vasodilator and goal-directed medical therapy are uptitrated as IV agent as well. The indication for invasive hemodynamic monitoring. Respiratory distress and impaired systemic perfusion with inadequate clinical assessment. Persistent heart failure symptom and unclear fluid status and perfusion status, uncertain systemic and pulmonary vascular resistance, then worsening kidney function to guide IV vasodilator and inotropic therapy, and to guide potential mechanical cardiac support and heart transplant decision. Then the recommendations are initial IV diuretic dosing should be guided by multiplying home total daily diuretic dose by approximately 2.5 and administering in either divided IV bolus twice daily or as a continuous infusion. It is recommended by the dose heart failure trial. Then subsequent diuretic dose and decongestive therapy should be titrated to meet acute decongestive goal. It is a decongestion goal. It is described by KRS heart failure trial. Then ultrafiltration is not superior to diuretic therapy and should not be routinely used over diuretic therapies in uncomplicated patient with acute decompensated heart failure. It is described by the KRS heart failure trial. Unless treating concomitant hypertensive emergency and dyspnea with impending respiratory failure, routine use of acute vasodilator therapy do not add benefit in acute decompensated heart failure is described by Ascent Heart Failure and the Galactic Rose trial. Then guideline-directed medical therapies for heart failure with reduced ejection fraction include AC, ARB, sacubitril valsartan, beta blocker, mineralocorticoid antagonist, and SGLT2 inhibitor should be initiated during hospitalization in hemodynamically stable patients who are appropriate candidate is described by Pioneer trial. Patient with acute decompensated heart failure should be screened for iron deficiency and treated with IV iron if deficient and even if not anemic. So it is described by AFFIM trial. Invasive hemodynamic monitoring and IV inotropes are only recommended in patient with heart failure with reduced ejection fraction complicated by cardiogenic shock as a short-term therapy. It is described by ESCAPE and OPTIM trial. Thank you, guys.